Good evening, everyone. Welcome to the December edition of the Scleral Lens Education Society webinar series. My name is Ashley Tucker, and I'm delighted to be your moderator for this evening. So tonight's topic is the 2023 Scleral Lens Research Update. And we are so honored and privileged to have Dr. Muriel Walker, Stephen Vincent, and Muriel Schornack tonight. So let me just give you a little information about each of our speakers. So Dr. Muriel Walker is a clinician scientist who specializes in anterior segment inflammatory diseases and specialty contact lenses. She graduated with an OD-MS degree from the New England College of Optometry in 2013 and went on to complete a one-year cornea and contact lens residency at Pacific University. She came to the University of Houston College of Optometry as an assistant professor in 2014 and in 2021 completed a PhD in physiological optics with a dissertation entitled The Impact of Scleral Lens on the Eye. She is an active fellow in the American Academy of Optometry, a fellow and past president of the Scleral Lens Education Society, as well as an advisory board member of the GPLI. Maria is currently a tenure-track assistant professor at UHCO, and the Walker Lab is focused on studying the role of immune cells in inflammatory diseases of the cornea and tear film, as well as the impact of scleral lens on the eye and disease in normal eyes. Dr. Stephen Vincent is a professor at the Queensland University of Technology and director of the Center for Vision and Eye Research. He has published over 140 scientific papers, primarily concerning visual optics, myopia, and contact lenses. He is a fellow of the Scleral Lens Education Society as well. And last but not least, Dr. Muriel Schornack attended the Illinois College of Optometry and received the valedictory award upon her graduation. She then completed a residency in primary eye care at the Illinois Eye Institute. Dr. Schornack joined the ophthalmology department at the Mayo Clinic in Rochester, Minnesota. She now serves as a consultant in that department and holds the rank of associate professor in the Mayo Clinic College of Medicine. She was instrumental in the development of Mayo's Community Eye Care Clinic and served as the medical director of that clinic from its inception in 2004 until 2012. She was also responsible for the development of Mayo Clinic's scleral lens program in 2006. She has published extensively on the topic of scleral lenses, and Dr. Schornack is currently a member of the editorial board of Eye and Contact Lens. She's a founding member of the Scleral Lens Education Society and received the organization's award as Scleral Lens Practitioner of the Year last year. She was also a founding member of the SCOPE study team and is still actively involved in the group's research activities. So as you can see, it is a complete honor to have this group of doctors talking to us about the scleral lens research update. These are all of their disclosures, but all of their financial disclosures have been mitigated. So just as a reminder, if you haven't joined us over the year, we do have a Q&A feature and a chat feature. So feel free at any point to put your questions into either one of those boxes, and we'll address the questions at the end. In order to obtain CE credit, attendees must at least be on this webinar for 15 minutes. Course handouts will be found on our website later this week. And if also one more reminder, if you haven't joined us earlier this year, in order to instantly receive your CE credit, you must download the OE Tracker app in the Apple Store or Google Play Store. Once you open the app, make sure your information is correct and then scan the QR code, and then you will instantly see the CE credit. But don't worry if you're not savvy with these sorts of apps, you will be getting an email within 2 weeks. So that's enough from me. I am happy to unshare and let Dr. Walker take over and start our webinar.
Well, good evening. I get to lead off here, and I'm delighted to be speaking with you for a while this evening again. So 2023, guess how many papers were published with regards to scleral lenses? Well, my count says 42. Your count might be a little bit different than my count, just based upon exactly what we include. But 42 papers is down just a little bit from last year, where it was 44 or 46, I believe. But still, it's a very respectable number, with 3 or 4 scleral lens papers coming out each month. 50% of these papers originated from the United States or Australia, but a very encouraging trend is that additional countries that have not been well represented in scleral lens literature are now coming on board, including the ones listed here. So we're seeing broader geographic distribution of scleral lens research activity. The usual suspects for journals are, of course, eye and contact lens anterior eye, and optometry and vision science. However, we're also seeing scleral lens publications being published in a number of other journals. And again, this is an encouraging sign that scleral lenses are moving out of a strictly contact lens space and into the treatment and management of ocular disease. The SCOPE 2020 study papers were finally published in 2023. We were a little slow in data analysis. We published 4 papers. The first took a look at who was fitting scleral lenses and in what kind of practices those people lived in. The purpose was to evaluate changes in international scleral lens prescription and management practices between 2015 and 2020. The SCOPE 2020 study was approved through Ohio State University and funded by Contimac. So what did we notice? Well, the major difference, we saw a whole lot more patients represented in the 2020 study compared to the 2015 study, nearly 3 times as many. And we also saw more countries represented, again, showing that the distribution of scleral lenses appears to be expanding geographically. Let's talk some more about some specific differences here. In 2020, we saw a higher percentage of practitioners who were practicing in non-academic settings. This would suggest that scleral lens prescription and management is moving out of tertiary care centers and into the primary care world, which is very good news for patients who need to access these devices. We also took a look at the year of first lens fit. Now, the light blue line was from the 2015 study. The darker blue line is from 2020. And if you take a look at the trajectory of that light blue line, it looked like scleral lenses were on an exponential ride towards the stratosphere. The 2020 study suggested, however, that we may be seeing a little bit of a downturn in that exponential growth of scleral lens fitters entering the market each year. So the market may be stabilizing just a bit. Again, the year of completion of training, the folks who were graduating in 2013, 2014 were all absolutely certain that they were going to include scleral lens practice in their careers. Those who are graduating a little bit later are perhaps being a little bit more interested in other things. So again, interest in scleral lenses is not dying, but perhaps that rapid growth is leveling off a bit. This was very interesting as well. The total number of lenses fit, as I mentioned earlier, roughly tripled with about the same number of practitioners. So it was not surprising to see increases in the percentage of individuals who had fit over 50 or even over 200 lenses from 2020 compared to 2015. The indications for scleral lens fitting stayed relatively stable, with corneal irregularity making up nearly 80% of lenses fit. Ocular surface disease remained steady at about 16%, and refractive error is still bumping along the bottom. We're just not fitting a lot of these lenses for the correction of uncomplicated refractive error. The most exciting thing in my mind of the SCOPE 2020 study is that scleral lenses overtook corneal rigid lenses as the first choice for the management of corneal irregularity. We asked practitioners to rank these options in the order in which they would consider them, and 268 respondents ranked scleral lenses first for corneal irregularity, with 132 respondents ranking corneal rigid lenses first. So scleral lenses are taking over the world, folks. We also took a little bit more of a studied look at complications associated with scleral lens wear. We asked about complications in the 2020 or in the 2015 study, but we really didn't have a denominator or a number of patients in whom those complications occurred. So we asked the participants how many patients they had evaluated during the past year, and then we further asked them how many of those patients scleral lens wear needed to be discontinued for due to a complication. This is not a true incidence rate, but it simply tells you the number of events, or estimates the number of events that occurred in a given population during a given period of time. Corneal microbial keratitis was the cause of discontinuation of lens wear in about 325 patients. 385 patients discontinued lens wear due to corneal neovascularization. Corneal edema was the most commonly reported cause for discontinuation of lens wear, with 869 patients stopping lens wear due to that complication, and 135 patients discontinued lens wear due to limbal stem cell deficiency. So that takes care of the scope study. My job is to talk about a few of the case reports. And one of the things that struck me as I was reviewing them over the last several weeks is that a lot of the case reports are dealing with uh, indications for scleral lens wear associated with ocular surface disease rather than corneal irregularity. And this could be indicating a little bit of a shift into more use of the devices for ocular surface conditions. Several case reports also reported utilization of scleral lenses in systemic disease. This case report was probably my favorite case report of the entire year, because all of us have seen patients for whom scleral lenses have been life-changing. And this actually documented the life-changing benefits of scleral lens wear in this patient who had undergone extensive lid surgery due to basal cell carcinoma. He was nearly suicidal before scleral lens wear, and once he was fit with sclerals successfully, found that he did in fact have something to live for. So all of you have experienced it, and now it's documented in medical literature. These are two representative studies that I found interesting with regards to ocular surface disease. Now, most of us would fit a patient who had undergone keratoprosthesis transplantation or implantation with a bandage contact lens, but in some patients that doesn't work. So the Boston Foundation for Sight group demonstrated that scleral lenses can be used to protect the ocular surface in patients with keratoprostheses. The next case report described very early utilization of a scleral lens in a patient with an epithelial defect following penetrating keratoplasty. I know I have personally wondered how soon could I potentially introduce a scleral lens after this surgical procedure. If there is an indication to keep the epithelial cells that cover the cornea healthy, it turns out that this study proves that you can do it very early on indeed. EEC syndrome is a syndrome that affects both hands and eyelids. Patients with this syndrome may have altered digits, so they may really have difficulties putting lenses on and taking them off. But as this study showed, the use of scleral lenses over the course of years can, in fact, be well worth the effort in training these patients to put lenses on and take them off, because they really do provide excellent surface protection. This study demonstrated the use of a scleral lens to protect the ocular surface after transplantation of oral mucosa onto the anterior surface of the eye for the management of Stevens-Johnson syndrome. We all know that that is a terrible anterior surface disease that can be visually devastating, and it's nice to know that not only can scleral lenses help, but there are other surgical procedures that may help these patients to maintain and even regain sight. I don't know how many of you have encountered patients who have undergone corneal neurotization surgery. I've attempted to fit several of them with a scleral lens, and it is challenging. If you take a look at the photographs, you can appreciate the elevated tissue overlying the nerve transplant directly next to the limbus, and to try to get a scleral lens onto that eye can be challenging. This group found that if you make the lens small, that you may be able to fit the lens within the gutter of the transplanted nerve, and therefore protect the cornea and provide good vision in patients who require scleral lenses for corneal irregularity as well as ocular surface disease. I had to include this case report because sometimes when we do our very best, perfect is the enemy of very good. So this study talks about the use of two wavefront guided lenses and the binocular rivalry that developed between the patient's two eyes with both of these. Now, I think that wavefront guided lenses show tremendous promise, but when we're dealing with patients who have not had excellent vision prior to the introduction of these lenses, it can be a little bit overwhelming for the cognitive evaluation of the neural system to address these and to interpret very clear images. So just be aware if you're going for the gold and fitting higher order aberration correcting lenses, it may take the patient a time to adapt, and you may actually have to settle for less than optimal vision in order to give the patient comfortable vision. We're going to spend just a little bit of time talking about outcomes reports. Retrospective studies on scleral lens outcomes have made up a huge portion of scleral lens related literature. And it's encouraging to see these outcome papers now coming out of Korea, India, and Japan. The first study described scleral lens use in 47 patients or 62 eyes with mixed indication and confirmed that scleral lens wear can in fact improve visual acuity in both patients with ocular surface disease and corneal irregularity. The paper from India was a retrospective review of 50 patients or 69 eyes, once again with mixed indications, and a large percentage of these eyes achieved visual acuity of 20/40 or better, both with corneal irregularity and Stevens-Johnson syndrome, which, as we discussed before, is a devastating ocular surface disease. And then finally, the paper out of Japan looked simply at patients with Stevens-Johnson syndrome and described improvements in both corneal health as well as visual acuity with scleral lens therapy. All three of the review papers that discussed scleral lens management and the treatment of various conditions dealt with ocular surface conditions. The first listed here talked about the use of sclerals in managing non-healing epithelial defects, visual rehabilitation after corneal disease or surgical treatment was described in the second, and then the third describes contact lens wear in dry eye disease and ocular surface disorders. So my hope is that with the use of scleral lenses or the presentation of scleral lenses in these reviews, that we will see increased use of the devices for ocular surface disease. I really do think that that is a tremendous growth area for us. Thank you very much. We will move on.
Thank you so much, Muriel. It's a pleasure, as our yearly tradition, to join the both of you to talk about research. So shifting a little bit to a different approach. So we're going to look a little at some of the papers and some of the research that we have on the scleral lens kind of physiological impact on the eye. And so before we do that, I just want to share just a couple of papers because it's always, part of our job here is to highlight 2023 papers. And so this was one of the recent 2023 papers that I found kind of interesting. And the reason that I chose this as a paper to highlight is because it is an incredibly good review on the use of scleral topography and the use of just profilometry in general in designing scleral lenses, and actually even talks about other types of contact lenses as well. So I'm going to go through kind of the highlights of it, but I would recommend certainly, one thing I definitely see as a trend in scleral lens fitting in general is practitioners who are at that beginner level and moving into the more advanced level. And oftentimes the conversation comes up of scleral topography. So I would recommend reading this paper to, in a way, prove to yourself kind of what can be done and gleaned from measuring the topography of the scleral surface in scleral lens fitting. So this first image is from the ESP, the eye surface profiler. So there's three typical instruments that are available in the United States. This is an output from the eaglet. Here's a schematic of how the images are taken using the S map. And so you have patients look straight ahead gaze, up gaze, down gaze, and those measurements are taken at those 3 different locations and stitched together for a profilometry map. And then this is the CSP, which is an add-on to the Pentacam, the Oculus. And again, you can see in the bottom right hand of this image, you can get onto the periphery and measure the either height or curvature, but ultimately it's building kind of a height map or a 3D map of that surface for fitting lenses. So again, this paper is a really nice review of different types of instruments and also different types of eye shapes that you'll encounter on the sclera. So here, the output is pretty similar to what you would see on an elevation map with a standard corneal topographer image. So the cooler colors like the blues and the greens are typically areas where the sclera or the overlying conjunctiva is relatively depressed relative to sort of a best fit sphere on that eye. And then if you look in the bottom right hand or the bottom left hand image in the top, you can see kind of those hotter colors like red or even white. You can sort of see white in this highly irregular image in the bottom right. And that's where there's high elevations relative to sort of the best fit sphere. So here's a good example. And, many of us who have access to these instruments have seen this, where you have patients come in year over year and their lens is pretty decentered. They have a pinguecular, they have some sort of irregularity or asymmetry where they're getting asymmetric blanching. In the past, we sort of had to make do with that or try our best to fit the lens as appropriately as possible, sort of making gross measurements in the slit lamp or even the OCT. So this is an example of a patient where scleral profilometry was used. This is an example of the eaglet. You can see they have bilateral nasal and temporal elevations. Looks like in this case, they have a pinguecula and they can use that. And you can see basically here a well-centered lens without sectoral impingement because you're able to design a lens that's appropriately fits that surface. Here's just another example. This is sort of showing first lens success with a design when using scleral topography. They do throw some soft lenses in here. So this is a soft lens before sort of on the top and after changing some of the parameters based on the measurement. So not just helpful for scleral lens fitting, but also for soft lens fitting. So I really enjoyed this paper. It's a very good summary of all the principles, all the most up-to-date kind of technology that we have, and some good case examples, and sort of helps, your fitting as well. So another paper that I thought was interesting from Gloria Chu, I'm actually not going to go over this paper. This is kind of looking at scleral lens replacement. So kind of a little bit of kind of what Muriel talked about sort of fitting trends and practice trends that we see. The reason I'm not going to talk about it is because Gloria is actually going to be presenting this study at the International Forum for Scleral Lens Research. So shameless plug for that. Here we have the IFSLR coming up. Both Muriel and I are moderating one of the sessions. Steve, unfortunately, can't be there, but whenever he is there, he will be. I will make him participate or ask him nicely to participate again. So that's going to be Wednesday before GSLS starts. You can register on the GSLS website or just kind of Google the name and find it from there. This is just an example, and not an example. This is what the agenda is. I think it's pretty finalized at this point. You can see the authors that Bita Asghari, we already talked about a paper she wrote. Steve's going to talk about a John Gelly's paper, Gloria Chu paper. So a lot of familiar names that we see here with the SLS as well as in the research arena. So hopefully y'all can join us for that. But so now kind of shifting a little bit, and I'm going to go through just more kind of focusing on how sort of two parts how ocular surface, and I know Muriel already kind of talked about the case report side of this, but I do want to share what we're finding. We're working on a systemic review, and there was a couple of reviews that Muriel referenced, which are very well done. And we're seeing more and more of these cases come up. And so we are working on a systemic review, and found, most of the papers are case reports, but there are some full prospective studies. Just sharing kind of the highlights of some of the studies that we looked at, and summarizing some of their major findings. We find, and you'll see this over and over again, scleral lenses improving the OSDI, ocular surface disease index score, and quality of life outcomes for patients with moderate severe dry eye. We also do see the start of some sort of more basic science approaches, looking at the presence of leukocytes. You'll see some of our research, we're looking at leukocytes in the tear film. This was looking at them on the conjunctiva in Sjogren's patients. Another paper here looking at scleral lenses improving objective outcomes in moderate to severe dry eye. One trend that you sort of see as I'm going through some of these is that most of these papers are in pretty severe dry eye. So graft versus host populations, Stevens-Johnson's populations, some of the conditions that Muriel was talking about in the first section. So we have to keep that in mind as we're seeing this literature come out. Again, scleral lenses improving OSDI scores. This last paper was in a cohort of GVHD patients, so very sick patients with very severe dry eye disease. The take home of this dry eye literature at this point is that symptom improvement may be the best indicator of success. You may see some sign improvement, but based on the literature, it looks like the OSDI is the best way to track the success of a scleral lens for patients with dry eye. You can see that the way they're scored, typically higher scores, or always higher scores, are more indicative of more severe dry eye. I've seen this myself in clinic. We now actually, because of these papers, give all of our patients who are dry eye related scleral lens wearers the OSDI before and after. You'll often see scores in the 70 or 80s for severe dry eye go down to the 20s or even the teens with scleral lenses. One thing to note, there really isn't anything published on sort of the more garden variety dry eye patients, so we have to sort of take this literature in context when trying to apply it to other populations. So moving into some of the research that we're working on, and there is another paper out this year I was happy to see that looked at some cytokines in the fluid reservoir. The primary work that we're doing in my lab is looking in some way at the scleral lens fluid reservoir. There's several impacts that this has on the scleral lens fit on the eye. Some of them we know a little bit about. Some of them are not particularly well understood. We do know a lot of the case reports and these papers I just talked about with ocular surface disease, that there's tremendous healing properties. Steve's going to talk more about visual benefits. Of course, we know there's many benefits, but it is also important to understand some of these impacts, and that's what we look at. Of course, this can be evaluated with OCT, so you can kind of visualize this in different ways. We remove the lenses, collect that fluid reservoir fluid, and test it for different things. In the literature, midday fogging is probably the most commonly kind of addressed fluid reservoir research. There's been several studies that have looked at its prevalence, finding it occurs in maybe a quarter of the population, more common in ocular surface disease. I like this image. It's from one of our study subjects because you can really kind of, in this case, this is a patient who has some midday fogging. You can sort of see the epithelial cells sloughing off of the cornea. We'll often collect this and stain it with simple cell stains. You can see that there's some epithelial cells in there. You might not have recognized them as that, but these larger cells are epithelial cells, and all these smaller cells are granulocytes, primarily neutrophils. So just to kind of give an update on, we have a couple of ongoing studies where we're collecting these from patients. So just a quick update on what we're actually doing and what we've been seeing. So patients who are coming into the University Eye Institute participate. They have to have been wearing lenses for 2 hours. We do the OCT to quantify the sort of turbidity or midday fogging score, as we call it. And then we do a little saline wash of the lens and collect it and do some testing. So what I'll share with you mostly is some of the cell testing that we've been doing. So we have this cell analyzer. It's usually used to analyze blood cells, but it can be used with any solution with cells in it. And essentially, we're looking at several different types of cells. These here are lysozymes, monocytes, neutrophils, eosinophils, and basophils from top to bottom. And that's just an example of the printout that we get, giving the percentage of cells in the population. So what are these cells? If you've heard me talk about this before, you've heard this before. These are immune cells, granulocytes. So typically they're for some sort of immune response. So continuing to learn about that, we do know that it is associated with midday fogging. You can see this is the data from 40 of our subjects who are all keratoconus patients. Definitely, this is not a normal distribution of midday fogging scores. So obviously only about 25% have significant fogging. So you see less people sort of on the right hand of this graph, but still we're seeing and this matches up with what other literature has shown, that midday fogging, at least in some patients, appears to be an increase in granulocytes, more specifically, mostly neutrophils in that fluid reservoir. We also looked at the cytokines and have been looking at the cytokines, and those are the inflammatory proteins in the tear film. So we've looked in keratoconus, compared them to some normal subjects, compared them to some RK subjects. You can see the red bars and the bright green bars are pretty similar if we're looking at these sort of 6 major cytokines that were detected in that fluid. And so they are higher than normal. You can sort of see they both kind of tower above the normal middle. And, we're increasing the number of subjects, but it looks like we do have some increase in inflammatory cytokines in these disease states. So still kind of, not super exciting in terms of what we can do to manage patients tomorrow, but the more we learn about these, the more we can develop solutions to mitigate it. So I do have a little bit of data that can maybe help some of us in clinic at least start thinking about this way. And this is a study that we're doing that's looking at preservative-free artificial tears as application solution instead of standard saline when you're putting the lens in. And so you can see this is just one subject, but this is a slit lamp image on the left and her OCT on the top right of when she used saline as the application solution. And on the bottom is after a week. So they used each solution for 1 week. Of the preservative-free artificial tear. We have looked at this in 4 subjects. So this is just one example. And we do start to see, and even with 4 subjects, we do get a significant p-value. But again, we're continuing and expanding and looking at this in more subjects and in different diseases. But it does look like the preservative-free artificial tears, which a lot of us sort of knew anecdotally, but again, as Muriel said, sort of documenting this in the medical literature is useful. So we also, this is interesting and actually was new. We also measured a couple of inflammatory cytokines in this tear fluid, which is interesting. So interleukin-6, interleukin-8, and VEGF. So VEGF is probably the most easily recognizable. Increases in VEGF could indicate a hypoxic situation or be indicative that neovascularization or other activity, biovascular activity is going on. So preliminarily, it looks like preservative-free artificial tears may improve midday fogging and reduce some inflammation, but we'll see how this pans out as time goes on. There was a paper that was published by another group. I was very happy to see that has also started looking, and there's been a few papers, of course, but this was a very recent one, And what they essentially did is they fit different normal patients with scleral lenses using preservative-free saline as their application solution, and collected so they actually collected not the reservoir beneath the scleral lens, they collected, it appears, from the basal tears or outside of the lens. So they had 3 time points before lens wear, after 5 hours of lens wear, and then 3 hours after the lenses were removed from that. And they looked at a whole host of different cytokines, which you can see measured or listed here on the right. Now, the thing about tear data is it sounds really cool and exciting, but it can be very difficult to compare studies to studies and to make big sense of the data when you just have one-off studies. So I appreciate this being added into the literature. You can see the different levels that were measured at the different time points. So we're sort of in the process of looking, and I think there's been a few studies now that have looked at different cytokines in the tears, and so we can start comparing them. And I hope to talk to this group actually, so that I can sort of compare our methods. And there is definitely a big effort internationally to standardize how we look at tear cytokines in all situations. So I was glad to see that this was out there. Okay, and lastly, I'm going to just kind of shift in my sort of evaluation of health and how scleral lenses impact the health. There was another paper published this year in an area that is dear to my heart, and that is looking at intraocular pressure and the impact of a scleral lens on the IOP. I think this is a slide that I sort of modified actually from last year or even the year before, when we had done a review on looking at the impact of scleral lenses on the IOP. Here we're looking at sort of a blown up OCT image of the anterior angle. You can see Schlemm's canal with the white arrow. We put the scleral lens on, and that could potentially compress that kind of entire architecture. Here's just a nice image anatomically from Dr. Bergmanson's clinical anatomy textbook that we used in our paper, just to show anatomically where that location is. So the paper that was done, this came out of Berkeley, Meng Ling's group, and they had fit normalized. So they actually, this was interesting, they looked at 2 different diameters, so 15.6 and an 18.0. They did Goldman at baseline for enrollment testing, and then they used the pneumotonometer, which basically measures the intraocular pressure over the top of the sclera, or over the top of the lid overlying the sclera. And they measured, they did all sorts of testing that you probably can't even read, and that's fine. It's just to show you there's a lot of testing. But essentially, they took these pneumotonometry measurements at 4 different time points during lens wear. So you can see that without scleral lens wear at all, this is a graph showing just IOP over a 5-hour period. It's going to be higher than corneal measured IOP. So in this case, fluctuating from about 22 to 23 without a lens on. The graph that is up now is showing the difference between the 15.8 and the 15.6 and the 18.0 millimeter lens. You can see the 15.6 is in the blue, the 18.0 is the dashed red line. Both of them showed a significant not clinically significant, a statistically significant difference of about 1.5 millimeters of mercury. So from a little over 22 to a little over 23 after 2.5 hours of lens wear, which was interesting. You can see lens side by side, they sort of have that same trajectory, maybe increase the pressure a little and then starts to level back out. So I find this very interesting. Again, adds to our understanding of how the scleral lens can impact IOP, not only right when you put it on, but over several hours of wear. I suspect that maybe there's some sort of initial response that then gets sort of equilibrated throughout lens wear. So, but again, adding to the literature, it'll be interesting to see how this stuff kind of pans out. So very, very last, before I will pass it over to Steve to finish this off, I cannot help but do another shameless plug. We have a current multi-center scleral lens study. Muriel is part of the study team on this as well, looking at microbial keratitis incidence in scleral lenses. We have many practices participating. Hopefully some of you are on here. Shout out if you are. If you haven't participated, look out. We're going to do another recruitment push in early January. But if you hear about this, email me, ask Muriel, ask around. We'd love to have any practice spinning any amount of scleral lenses is eligible to participate. So with that, I will go ahead and pass it over to Steve to finish up for us here.
Thanks, Maria. So I'm going to start off talking about corneal edema and scleral lens wear, which is something our lab's been interested in for sort of the last 10 years or so. And this slide sort of just summarizes the work that's been done previously. So a lot of people have looked at the effect of altering the decay of the lens, and we get some reduction in scleral lens edema when we increase our lens decay to about 100, and then beyond that we don't get much more benefit. If we alter the thickness of the lens, so we try and minimize the lens thickness, we can get some better improvements in reducing edema. And sort of the greatest impact we can have is just minimizing the clearance that we have, so making that post-lens fluid reservoir thickness as thin as possible. And all of these previous studies have basically looked at the central cornea. So we've been interested in sort of starting to look towards the limbus a bit more. And particularly because there was a nice theoretical model from the team at Berkeley who looked at, okay, we have this theoretical model for soft lens edema and scleral lens edema. And they modeled how much edema you would get centrally and what happens out in the periphery towards the limbus. And so we thought, okay, we'll look at that with some of the data that we have from our laboratory and compare it with their model and see what we find. So we had some short-term data. So this is young, healthy eyes without any corneal disease, where participants had worn the lenses for 90 minutes. We measured how much the cornea swelled, and we looked at that in the center and out towards the limbus as well. And we did that for a range of different fluid reservoir thicknesses, so low, medium, and high level of clearance. And what we found was for across like the central 5 mil of the cornea, the magnitude of edema is quite stable across that area. And then as we approach the limbus, it does seem to increase slightly, which we found interesting and hasn't really been reported previously. And we compared this measured data that we had from this particular study with the theoretical model from the Berkeley team. So the Berkeley team, they sort of had two different ways of modeling. They had one approach, which was, okay, in this model, we're going to have this limbal metabolic support where there's oxygen coming in and we're removing carbon dioxide and what have you. And then we'll have another model where there's no support at the limbus. And our data seem to mostly agree with their no limbal metabolic support. So this is interesting. Of course, their model didn't account for tear exchange, and perhaps that's what we're seeing. We don't have much tear exchange going on with scleral lenses, but it sort of raises the question, how do we manage this clinically? If we are inducing more edema at the limbus, can we modify our lens fitting, reduce the fluid reservoir even more so in the periphery, or do we need to somehow modify the fit to improve tear exchange? So a looser fit, or fenestrating the lens, or coming up with some other lens modification to try and get more oxygen or allow more exchange of metabolites in that peripheral region. So this is an active area of research. So one of our postgrad students, Asif Iqbal, he did that study looking at the central versus the peripheral edema, and that's an area of research that he's continuing on for the next couple of years. So I'm going to move from edema to sort of optics now, and there's been a number of studies published recently looking at this, which Muriel talked about in terms of case reports. So this is something that we're interested in the lab, also trying to optimize vision in scleral lenses, which sometimes can be more challenging than a corneal rigid lens. So the ideal scenario that we have is that you sort of have this perfect scleral lens fit. and you align the optics perfectly with the pupil, but often the fit is not 100% perfect. It's good or it's great. And you neutralize most of the irregular optics of the anterior cornea, but you somehow have these residual leftover higher order aberrations due to an issue of fitting of the lens. The lens is tilting or decentering slightly, or you've masked all the front surface irregularity of the cornea, and now the back surface or the internal irregularities come to the forefront. So you have a manifestation of aberrations from the posterior cornea or the crystalline lens. So how do we address that? Often the first step is just improving the fit, so trying to improve the centration of the lens or offsetting the optic zone so it aligns more directly with the pupil, minimizing your fluid reservoir thickness to try and stop decentration, fitting a customized back surface if you haven't done that already in the landing zone. Although we do tend to see some decentration even when we fit with a toric on the back surface. And this sort of comes into play, the decentration, is particularly if you're fitting an A-sphere on the front surface. If the lens is decentering, you're going to induce a bit of coma. So that can be problematic, or it can work to your advantage, as I'll demonstrate. So if we have the perfect fit or our ideal fit, but we still have these residual higher order aberrations, so not necessarily lens flexure or internal astigmatism, which you can address with fitting or a front surface toric. If we have these residual, say, spherical aberration or vertical coma, we need to sort of modify the front surface to try and mitigate those. So this is an area that's been looked at for many years. So in the 2000s, people were trying to do this with soft lenses. So either putting an A-sphere on the front surface of a soft lens or correcting all the residual aberrations up to the fifth order, say, by putting a very unique curve or custom ablation on the front surface. And it was basically just too hard, and it didn't work out with soft lenses due to lens movement, lens rotation, and too many other factors. But in the 2010s and beyond, when Scleral sort of came back into vogue, so to say, people thought, this lens is really stable. Let's modify the front surface optics on the Scleral lens, and we'll use that as our really stable platform. The lens won't really move, doesn't rotate too much if we lock it into place. And so we can put a very unique front surface curve on the lens and try and have the optics align with the pupil as best as possible and neutralize all the residual aberrations, not just the sphere and sill. So a lot of work has been done on this from the team at Houston, and this is some of their work here in the study on the left, which is the bar graph. They did some modeling here looking at what if we center our optics just in the geometric center of the lens and place that theoretically on the eye, and what's our improvement in vision. And they compared that to what if we, customize where the optics is to the pupil center, and they found that yes, theoretically you'd get much better visual outcomes if you customize or offset the optic zone, which is sort of what you'd expect. And then on the right, we have a case report from the same group, just sort of highlighting this. So a patient who is fitted with a standard Scleral lens with a spherical front surface, and then a wavefront guided Scleral lens. So applying that unique front surface curve. And the vision didn't actually improve. The optics was still bad. And that's because the lens was decentered. And when the optics was more closely aligned to the pupil, they get a much better improvement in vision. So that's been demonstrated in a few case reports now. This is more work from the Houston group, a very nice sort of longer term study looking at, it was very well controlled. So an 8-week conventional Scleral lens with a standard front surface compared to 8 weeks in a wavefront guided lens, and the visual outcomes were much better in the wavefront guided lens. And in this study, the group found that the vision at the end of the 8-week period was sort of better than they'd found in previous studies, and they suggested this is probably due to a bit of neural adaptation. So maybe patients who have long-standing keratoconus and have been not had these higher order optics corrected for a long period of time, it may take a bit of time for the acuity to improve. So how does this apply in clinic? This is just a nice case study from John Gellies and his team looking at a 28-year-old keratoconic patient who was 20/30 unaided and desired to be fitted with sclerals, and was fitted with sclerals, and the visual acuity was 20/30. So they didn't really get a significant improvement in acuity with the scleral lens. And taking a measurement of the residual aberrations with the standard scleral lens on eye, there's a lot of leftover coma and spherical aberration. So they designed a optimized front surface for this patient, and when that was applied to the eye, vision improved to 20/20. So they really knocked out that coma and spherical aberration. So that was with a fully customized sort of front surface lens design, correcting all the aberrations from both horizontal vertical coma, spherical aberration, and so on up to the fifth order. So trying to correct quite a few optical terms. But if you don't have access to that technology, what else can you do? Can we just put an A sphere on the front surface and try and minimize spherical aberration and maybe a bit of coma if the lens decenters? So a number of groups have looked at this, and these studies that I'm talking about here, they've really just used a trial and error approach where they've had a suite of scleral lenses in their practice with a range of different front surface asphericities or eccentricities. And they've tried them on the patient's eye and sort of gauged by visual acuity or subjective feedback which one gives the optimum vision. And the study here highlighted in red was a large study in India of 200 or 300 keratoconic patients, and that's the distribution of front surface eccentricities for which gave the best visual outcome in those patients. So a little bit of trial and error if you don't have an aberrometer to measure residual aberrations. But we've done some work in the lab to sort of try and predict what sort of front surface curve you might need for people. So we just had healthy people in the lab who wore a lens that had all the same parameters, fitting was the same. And the only thing that we altered was just the eccentricity on the front surface. And we measured the residual optics, or the change in the spherical aberration and coma really, over a number of different pupil sizes to see, how could you apply that in practice. So what we found was in this study, you could reasonably predict what the magnitude of change in spherical aberration and to some extent coma as well would be for a range of different pupil sizes as you change the front surface eccentricity. So if we know the change in spherical aberration that we're going to get for a certain pupil size, we can kind of work backwards. And if we have a patient in our practice and we know they have X amount of residual aberration left over, and we know the pupil size is X, we can have an educated guess at what the front surface eccentricity might be best for them. So here's just an example of how we would apply that to the case report that John Gellies' group published. So here we have our keratoconic patient with the residual aberration profile with the standard scleral lens on eye. We measure the amount of spherical aberration and their pupil size, and we plug that into our data that we have from the lab. And this is sort of a visual simulation of what we would get. So this is a front surface sphere, which is the same as what John's presented in his diagram to the left there. My modeling is a little bit grainier compared to his. So we've got the sphere, we've got the wavefront guided correction and the predicted retinal image quality. And if we put an A sphere on the front surface of the lens based on what we model in our lab, this is what we get. It's not, the visual outcome is not as good as a very customized wavefront guided front surface, but it lands us somewhere in between just a standard scleral lens and a fully wavefront guided lens. So if your manufacturers can't put a fully customized front surface higher order aberration correction on the front surface, you may be able to just request an A sphere if you have some knowledge of what the residual aberrations are for your patient. So future research in this area, some of the groups around the world are starting to look at, what are the effects of modifying clearance, lens centration, the tilt of the lens, and so on, in healthy and keratoconic eyes, and predicting what the visual outcomes are. So trying to optimize the fit, generalize these things so we get a better understanding of the effect of lens fitting on subtle variations in visual outcomes. And we're starting to do some of this as well at QUT, and hopefully I can give you an update that on the research update next year or the year after. So thanks for attending this evening.